covering the breadth that needed to be covered this morning. We're going to begin with some questions from our audience that were pooled throughout the morning. If there are any questions from this audience as well, we'd love to hear those, and then we'll move on to some CME questions. So the first one is for Dr. Graf. If patients were treated with ibrutinib, had AFib or severe cardiac probes, and ibrutinib was discontinued, can the patients still be given Xanu? It could be these two if that's easier. It's hard to hear them. It's like multitasking in your head.
So that's a good question. So if the patient had to stop ibrutinib, not due to progression of disease, very key in all this, but stopped because of the cardiac AEs, then yes, a patient could be switched to Xanu. Unfortunately, we weren't able to really look at the AEs in depth in the trial. I did show that one table, and we saw that the cardiac AE profile for Xanu in the head-to-head trial in Alpine, was very, very low compared to ibrutinib. So yes, if I particularly had a patient who had cardiac AEs such as AFib or hypertension on ibrutinib, I would certainly switch to Xanu.
That's great. And I know you touched on MRD already, but we did have another question about the clinical utility of testing in the community, and how and when would you recommend using MRD testing?
So specifically in CLL, I think the utility is, as we've seen with these studies, it's all about fixed duration, MRD driven. So how do you not test MRD?
Right.
So what I try to educate, at least in my own practice, and I've sort of helped actually implement an order set so that this isn't just being tested, willy-nilly, if you will, but that every patient diagnosed with CLL, just like they should have the cytogenetics tested, I think should have an MRD, or what's called an ID. If you're using the clonoSEQ assay, it's called an ID done at baseline. So you identify their unique sequences. And for a lot of our patients with CLL, they're not treated for a long period of time. So you wouldn't continue using MRD testing in them. You're not doing anything. So you have to make sure that's, it's not just a new test that should be done on everybody. Right. But if you are starting treatment, and depending on what it is, then I think that there are key time points, in which, MRD testing could be done. Again, it's going to be very personalized, and it might be in a patient where you're questioning, are they responding, or a patient who comes to you and says, I've got side effects, I don't want to take this drug anymore. Well, it might be, useful in that case. We see with the MRD-driven regimens specifically, Ven, OB, and what we're going to see here soon with, ibrutinib and Ven, and based on the Captivate and Glow, is that really your treatment decision at the end of therapy, really needs to be driven by MRD. Now, is it done routinely? No, it's not. I think people just stop treatment. But if you really want to have a scientific and clinically relevant decision-making process with your patient, I think that is a space in which, at the end of treatment, that needs to be done to make further distinctions on, okay, what's next? Mm-hmm. So.
Dr. Yeh, I'd like to extend this question to you as well, because, one thing that struck me in the CLL talk is a lot of these trials included fixed duration. And we have other cancers in which there are paradigms for fixed duration therapy, prostate cancer being an example, recognizing the burden of treatment and toxicity on patients over time. That's something that's been maybe underexplored in myeloma, but is becoming more and more part of clinical trial design. And so I would love to hear your thoughts on the use of MRD, and specifically on the future of using MRD in terms of fixed duration therapy for myeloma.
Yeah, I think that's a great point in terms of, when we think about myeloma therapy, we think about, they're on this treadmill of therapy, and that's why the CAR T cell therapy is such a potential game changer for being one and done. And, for myeloma therapy, one of the current paradigms is, treatment until progression and treatment long-term based on the well-established data for maintenance therapy with lenalidomide, and improvements in overall survival, and that's extended to, for relapse trials as well, where patients are treated until progression. And I think the next, one of the things I didn't get a chance to comment on in terms of, the next frontier in myeloma therapy would be, in myeloma therapy, we're so used to going from doublets to triplets to quads, and we keep adding things and adding combinations. But I think the next phase in myeloma care will be to de-escalate therapy and to better identify patients who can de-escalate treatment or do a fixed duration of therapy. And I think the MRD testing will play an important role for that to better identify those patients. So there's increasing data looking at sustained MRD negativity for, say, 1 year and the outcomes of those patients. I think people are exploring taking patients off therapy on that. But one limitation is that we're really awaiting randomized data to better inform patients from sustained MRD negativity, identify those patients who can come off therapy in terms of the we're awaiting the clinical trial data to inform that, and there are ongoing clinical trials with that. And in terms of the fixed duration of therapy, the bispecific antibodies, one thing in terms of like specific, we saw with the teclistamab is this high rate of hypogammaglobulinemia and rate of infection, and is that a class effect? Is that unique to teclistamab? It's really hard we're still waiting longitudinal data to play that out. But I think because of that, there is increasing interest in doing a fixed duration of, say, these bispecifics to better, potentially limit that risk of infection, as well as also I'm just thinking about the patient experience. So I think those are all important things too that we await, further clarification on.
Great. Thank you for those answers. So now I'm going to move on to some more questions for you. This is from our viewing audience. What is the cost of CAR T, including cost for monitoring? A myeloma patient cost can be up to $10 million and is still incurable, and now CAR T another $1 million that's still incurable. What are your thoughts on the relative cost?
Right. I mean, I think that's a complicated. These are good, complicated questions, right?
Yeah.
And I think Betsy probably could take a stab at this, given her background in myeloma too. But anyway,
I like to watch you flounder instead.
Right. So the CAR, myeloma therapies, we do combinations. So the yearly cost is hundreds of thousands of dollars easily, and then CAR T cell therapy, ide-cel and cilta-cel is about 400,000 or above. It's north of 400,000. So. When I think about cost of the therapy, at the end of the day, I think about, there's the cost to society and then there's the cost to the patient. And so for me, if I'm seeing the patient in front of me, I tend to think more about what's the actual patient on the hook for a cost. So fortunately, for the most part, the patient undergoing, ide-cel, cilta, they're not actually seeing that full cost, but they are seeing the cost of, driving in, appointments, parking, burden on caregivers. So there's that more tangible cost, but the actual financial cost of the patient, it isn't really that much. But I do agree with, there's the cost to society, and we're all at some point on the hook for that cost, and there's a limit to how much can we afford that. At the same time, I also realize that, the cost of CAR T cells is sort of being driven by what the market will bear. And that's just the reality, right? I'm just thinking about, I'll go there. Well, there are all these CAR T trials done in China, and I can't imagine that these trials, in the various facilities, and if it doesn't cost $400,000 to make a CAR T, I mean, I'm sure Dr. Cohen, in your lab, you can make a CAR T cell therapy for relatively, not that expensive. But again, I do appreciate that the cost does reflect the clinical development, all the regulatory burdens associated in terms of getting these studies to meet the mark in terms of FDA approval. So I think some of those costs are baked in there as well.
Can I comment?
Please.
So I'm gonna slightly, we want this discussion, right? So I'm gonna disagree a little bit. So I'd say, when a product is $500,000, even if a patient is not bearing that cost, we are all bearing that cost, and that is a problem. And the reason that we are at the point that 30% of patients are getting these therapies is because the system isn't working. So I would say we all have a real responsibility, but rather than talking about cost per se, I think we have to focus on value, right? And there are actually structured, thoughtful ways of assessing what the value is. Sadly, we say, okay, what is the price of a childhood immunization, or price of a COVID therapy, or price of a CAR T cell therapy? And there are actually academic frameworks for assessing that. And one of the ways is to, there are looking at incremental cost effectiveness ratios. and indeed, what is the cost of the therapy relative to the quality-adjusted life years that are gained. And there are frameworks. There is, NICE in the United Kingdom, and ICER is a nonprofit in the United States that does do analyses. I was actually one of the couple of outside experts when they did their first analyses of axi-cel, Anticigen, Leclocel. And at the end of the day, these therapies, even though they're very high, and again, remember that $475,000 product cost is not the cost of the product, because we have to hospitalize patients for several weeks and do lots of supportive care, lots of monitoring, so it is way north of that. But I think we have to think about the value of these therapies, and I think we have to say, what are the various approaches that we can use? There are actually accepted numbers and thresholds for cost per quality adjusted life year gained, and that is quite different, for example, if you're curing a pediatric ALL patient with one infusion of CAR T cells and they're going to live 70 years, versus if you treat a patient with ide-cel. And the depressing thing for me and my friend Sergio's paper is that there was no plateau, right? There was an improvement in progression-free survival relative to standards of therapy, but there was no plateau. So obviously, if you have a 77-year-old myeloma patient and they're getting a modest benefit, that's going to be different, right? So I think, I'm not saying that there's an easy answer. Obviously, what we need are progress, and these are transformative, critically important therapies that are saving lives. But I think we do have to figure out all of this together, and I would say everybody from a developer to an investor to a clinician, we all have to think about these frameworks and think about how we're stacking costs and how that affects both the individual patient, because many patients actually aren't getting these therapies because of these costs. But I think we have to have honest academic frameworks, and I think we don't do it often enough as a critical part. We're used to thinking about progression-free survival and SAEs and overall survival, but too little attention is actually paid to that.
So these are
component value.
Yeah, so this is fantastic, and you literally brought up the 2 points that I had written down and wanted to discuss. One of them is the relative difference when we assign value. So you showed that 43% of patients are cured by CAR T-cell in the lymphoma population, whereas they're not cured in myeloma. How much does that matter? We've seen 2 years of improved survival through cilta-cel, but when we think about the value we assign to that, these are hard questions to answer. And further, you also showed that only 30% of eligible patients are having access to these therapies. So when we think about therapeutic development, is it better to invest the time and resources in developing excellent therapies will be available to the few, or investing the time and resources perhaps in bispecifics or other types of therapies that may be more easily expanded to community practices so that we have greater accessibility to new therapies? And so I think that access is both financial, but it's also logistical. And so if you have a family, if you have a sick loved one or someone, a job, you can't access these therapies. It's not just the financial barrier, it's the life barrier. So I think that also has to be an important consideration in our drug development when we think about access and opportunity, because 70% of the eligible patients are not getting access to these therapies.
I might put another, just to be contrarian here.
You're always contrarian, Andrew.
Yeah, in terms of like how we benchmark I think we all can be right at the same time.
That's right, or we have to ask the questions.
And I think you do have to ask the question. I think in terms of, yes, ide-cel, they're not cured. I mean, CAR T-cell therapy in myeloma is not curative, and there are probably multiple reasons. Is it, some of it might just reflect the underlying biology of the disease, whereas lymphoma is inherently curable, whereas myeloma is not inherently curable as of this time. And that probably plays out to, how you can have curative therapy with CAR T from a lymphoma, but not yet with myeloma. But I think from the patient's perspective, I think of the patient in front of you, I think that even if it's 6 months, 1 year, 2 years of treatment, of a treatment-free interval, that's a game changer for these patients in terms of their quality of life, etc. Even though it's not curative, I think the patients, would line up to have an opportunity at that. Now, in terms of the cost issue, in terms of how such a depressing few number of patients have access to these therapies, I mean, I don't think it's inherent to the actual therapy itself or the cost of therapy itself. I think a lot of it is the logistics in terms of, these are larger, more societal questions and not so much, related to that product itself or how it's, or, I think there's some larger, insurance, legit, in terms of, there's some broader societal structural questions. And I don't think, those are important questions, but I think they're beyond, getting, what as an, I think those are super hard questions to answer.
But
maybe that's why I'm dodging the question.
No, but let me just say, I think that one of the things that's happening, and all of the companies that are developing autologous therapies are also thinking about allogeneic therapies that can be produced from a pool of donors at much lower marginal cost. So I don't think, right now, obviously autologous therapy has been, revolutionary, and I'm not taking away at all. I don't think we're disagreeing about the principles or the fact that even a transient response might be very, very meaningful, both financially as well as clinically, right? So, but I think we have to think about how we improve the field. How do we get better scale, more rapid times for ide-cel and cilta-cel? We have manufacturing issues that are actually decreasing access for patients who need them now. So all of this, these are all things as we think about where we want to be 5 years from now, 10 years from now. I think we can't just say, it's all fine because this is good, right? We have to say, here are the things we want. We want those response rates and progression-free survivals to be 70% or 80%. We want there not to be socioeconomic or racial disparities, and we want therapies to be delivered, closer to where patients live, as opposed to in a tertiary center requiring hospitalizations, or even with bispecifics. Even the elimination of the need for 24 hours of observation will make a big difference. So I do think we need to think about these things without necessarily saying that we're failing, but I think we need to, these are all challenges and things that are critical, and as we look at trials, as we look at emerging therapies, we should both evaluate the strengths of clinical outcomes and PFS and overall survival curves, but also these overall logistic and financial considerations.
I think the one take-home message, and I'm not so much for myeloma per se, but we're getting to the point in CLL, and non-Hodgkin's lymphoma where our chemo is cheap, but our chemo is not enough. So these therapies, we have to look at these things because our chemo is going to be archaic pretty soon. And so if we don't take these things like we're just talking about into strong consideration now, we're not going to be doing our patients justice.
Absolutely. So moving away from cell therapy, I do have some other questions that I want to make sure I address because I think it is good in the context of myeloma to think about IMiDs and also the cell mods. And so one of the viewers from the audience asked why pomalidomide was not used in the frontline setting trials, and asking also if pomalidomide or iberdomide might replace lenalidomide in the future for first-line therapy in myeloma.
That's a good question, right? Because I think, why isn't pomalidomide been studied for first-line therapy? Because we do know that pomalidomide is active in lenalidomide refractory disease. And I think one of the themes in myeloma care is to use your best treatments first, don't wait for later, right? That's sort of the ongoing theme. So then the audience question about, well, why do we use lenalidomide? Why not use pomalidomide if it's more effective? And I think that gets to some broader structural questions that are sort of beyond I think there's some broader, questions. I think that's a question you have to ask, the pharmaceutical development. I think it relates to how these drugs are developed pharmaceutically, and there's some business type, there's some financial, commercial interests at play too. I think would probably be my cop-out answer to this.
And finally, another one is just.
But to follow up on that, I do think. Lenalidomide's now, generic, and I think so that could play a role in terms of access to it. Though, even though lenalidomide's generic, the cost of it isn't really that much cheaper than brand name lenalidomide, because again, the generic pharmaceutical companies want to maximize their return as well. But I do anticipate that with these new cell mods, again, they're more potent, they're more active, and I do anticipate that they will play a role in. They have the potential to displace, lenalidomide and pomalidomide down the road.
Great. And on a practical note, as daratumumab moves into the frontline setting and patients are now refractory or exposed in the second-line setting, what are your recommendations for your first choice for second-line therapy? And would you consider retreatment with daratumumab or alternatively isatuximab in the second-line setting?
Right. So, the question is about, now that daratumumab is being used more in the front line, what do you use, in second line? A lot of the trials with darapom, CD38 pom dex, CD30 antibody carfills with dex, or lenalidomide. I'm sorry, CD30 antibody naive patients. So what do you use? Now, are you using all your therapies up front? So for patients who are relapsing, then I think more about pomalidomide. I think more about carfilzomib and cyclophosphamide. So for example, in somebody who's relapsing after DARA-R, suppose a patient has decided to go the Maya route and did DARA-R and they're relapsing, then a regimen that I'm using would be like, say, pomalidomide, bortezomib, and dexamethasone. Or a patient, so pomalidomide and carfilzomib, cyclophosphamide-based regimens, those become increasingly used in those lines of therapy.
Thank you, Dr. Yee. And I do want to take the opportunity to see if there are any questions here in our live audience that patients may have wanted to ask. Participants may have, sorry, one-track mind. Yes, please.
So Dr. Graf, question for you. Number one is that do the clinical trials answer the question that Xanu has less risk of intracranial hemorrhage when used in conjunction with anticoagulation? And in your clinical practice, if you have a patient where anticoagulation full dose cannot be stopped, do you feel comfortable using Xanu?
I'm not exactly sure. I'd have to go back and look at the intracranial hemorrhage. That's not something that I have off the top of my head, and perhaps maybe some of the people who work on Xanu in the room can answer that question later for you. But no, I don't have concerns if I have patients, and I do have patients on full dose anticoagulation. I don't hesitate to use Xanu. I mean, I monitor the patients the same way I would in any other respect, but no, it's not I'm aware of percentages. I mean, we know there's a bleeding risk with all the BTK inhibitors. I mean, it's, something we all see percentages on, but in the real world, I have not seen, I haven't had to stop therapy on anybody who's been on full dose anticoagulation.
Thank you for that answer. Any other questions?
I wanted to just a follow-up point about what you asked earlier is really a critical question across diseases, and that's that I think the way, especially as we have increasing either bispecific or monoclonal antibody therapies and then CAR T cells, one thing we really don't know across diseases is how does prior exposure to one of these therapies influence our ability to use another therapy down the road. And I think this will be increasingly difficult for all of us because the trials won't address this issue and we'll have heterogeneous populations. But notion of how does exposure to an agent affect antigen target density and how does that affect your ability to salvage patients will be increasingly complicated. And I think it's something that's really going to be a challenge for the field.
So I did have one other question for you, which is very much in that same vein. It's about, are there ways that we can predict response? And so I think, you presented a slide that discussed this, but I think all three of our authorities here might be able to comment, especially, today we saw that there were so many available therapies. So is there a next role going forward in trying to identify personalized medicine, especially when these are high-cost therapies? Who is most likely to respond to what? Love to hear from everyone.
Yeah, so I think first, what's quite remarkable is I think that traditional risk factors that are not molecular, related to bulk of disease, performance status actually still have great value, right? So those will, I think, are and will continue to be a factor. I think that there are unique, again, exploratory analyses. For example, what happens in terms of to a patient based on pre-existing target density. I think that the work from the Stanford group looking at CD19 data by quantitative flow cytometry, and they have early data in their CD22 trials of patients who've already failed a CD19 CAR T cell therapy that similar principles may hold. So that's interesting. I think another, and then you can say in a separate way, what's happening as you administer a product? The data from Satva and colleagues suggesting that the 5-year response rate may have to do with how the cells are expanding in the patient. These are things that we don't typically kind of note as a potential predictor of relapse. And then the thing I did not talk about, but I think is exciting, are liquid tumor biopsies or cell-free DNA as a marker. And again, I guess that's contiguous, I guess, with the MRD talk of patients who may not have responded the way that they appear to by radiographic analysis and might need another intervention or might be at higher risk for progression. So those are just some of the things I could answer in other ways, but I would say a combination of molecular, clinical, and then these novel emerging factors I think will help us a lot.
I think in CLL, obviously really knowing the cytogenetics, I can't stress that enough, how important that is. But, okay, so we know patients have high-risk cytogenetics, and, I think we're going to see over time as these curves, we're getting, 5-year follow-up data now from, Elevate with Acala and OB. We've got the CLL follow-up. I think as we look at these curves and these plateaus, are we going to see a drop-off in these higher risk populations? Now, again, we're not doing cross-trial comparisons. I mean, we shouldn't be doing cross-trial comparisons, but we're not comparing them head-to-head is what I meant to say. And so right now, our best guess is, looking at things side by side and, making our own inferences from there, which is not necessarily the best thing, but that's what our current tools until some of this data continues to read out. But for TP53, it's also been suggested to look at the percent. Like, is there a difference? Is it just, I have the TP53 mutation, or I have, 50% of my cells that have this mutation? Like, is it coming down to that minutia when you're really looking at personalized medicine? And I think in CLL, it's such a molecular-driven disease. Fortunately, most of the therapies we see over a 5-year period of time seem to all do a very good job. But what happens then? Because it's not going to be enough. And I think there's a lot of nuances in using MRD and looking at not only are they MRD positive, but okay, you being MRD positive and me being MRD positive, our disease kinetics might be completely different. So I think, just using all those factors, to be able to identify some of those things and truly follow people in a personalized way, and that's the word we keep using here, is going to be key.
I think that I completely agree that I think the clinical characteristics seem to really be the key one of the key factors in terms of individualizing therapy for myeloma patients. Now, I wish, I think the holy grail would be, okay, you take the patient's blood work, and then, okay, based on this blood work, you pick, regimen A versus regimen B. But that's been talked about for years and years, but we haven't really quite reached that point in myeloma care yet, and a lot of it is driven by clinical characteristics, as well as some input from high-risk features based on the cytogenetics. I mean, the one possible thing that could be for individualizing patient care would be, for example, this I talked about in the presentation, would be the translocation 1114, which has the potential to identify patients who have unusual response to BCL2 inhibitors, but I do acknowledge that using venetoclax for those patients is off-label.
I guess my one follow-up to that is, when you have multiple bispecifics or CAR-Ts available with different targets, will you ever look at expression profiles to decide what might be the best CAR or best bispecific for a patient?
Right. So, expression profile for myeloma has been around for decades now, but that hasn't really taken. They have all these different molecular subtypes, but that hasn't really taken off yet in terms of being able to identify patients. So, I'm not sure if that's I don't get the sense it's being incorporated yet in terms of identifying, which bispecific to choose or which, CAR-T product to choose. I think the decision to choose which CAR-T product, again, is really being driven by patient characteristics as well as availability of the CAR-T product as the dominant factor.
Yeah, going further, I mean, it makes sense that, for example, somebody who has homogeneous high expression of a target antigen would be more likely to respond to somebody who has tumor heterogeneity or lower amounts. But think about it, in the pivotal trials of CAR T cells, we didn't even require assessment of CD19 expression. So let's step back and think about where we actually are clinically. And in some cases, ironically, even though we would say intellectually it should matter, it actually doesn't matter so much. If you even look back historically at the role of tamoxifen in ER negative breast cancer, other places, sometimes there are benefits even in populations that you would think intellectually might not respond. So we have to, I think, both be looking at these things, doing very strong translational work, but also being humbled by what the data will actually tell us.
Well, I think this has been a great morning. I appreciate the participation of all of my distinguished speakers here this morning. I'd like to give them all a round of applause. And we are definitely at time, and I'm sure everybody is hungry, so please, we'll break for lunch. Food is in the exhibit hall. We'll start back up at 12:45 in the meeting for the investigator session. And thank you to all the virtual attendees. We'll look forward to seeing you tomorrow morning at 8 o'clock. Thank you.